Thank you for joining us today. My name is Paul Rothman. I'm the Dean and CEO of Johns Hopkins Medicine. I'm here today to talk to Dr. William Moss, who's a longtime expert on vaccines. He has spent his career focused on vaccines, not only on the science, but how to deliver them effectively and equitably. Bill is the Executive Director of the International Vaccine Access Center and a professor at both the Johns Hopkins School of Public Health and the School of Medicine. Today, we're going to be talking about COVID vaccines and how the vaccination process is going both nationally and internationally. It's a complicated topic, one that I know Bill has thought a great deal about. Thank you for joining us today, Bill.
Thank you very much for having me, Dean Rothman.
So, Bill, how's it going? How's the U.S. doing in their vaccine distribution?
Well, Dean Rothman, I think it's really important to just pause and reflect on where we are right now with COVID-19 vaccines, because it really is truly remarkable. Somewhat over a year into the pandemic, we have multiple safe and effective vaccines, 3 vaccines against COVID-19 that have been authorized for use in the United States. And that is a truly remarkable scientific and public health achievement.
You know, it is amazing. You talk about that. If you could compare how long it took to develop these vaccines versus others, just for people, how much quicker was it than it would normally take to develop a vaccine?
So from the time the pandemic was recognized in December of 2019, it took about a year to get COVID-19 vaccines authorized and in use. This is a lot faster than previously. I think the prior world record was for mumps vaccine, which took about 4 years, but many vaccines have taken a decade or more. But I also want to emphasize, Dean Rothman, that there was decades or more of work prior to the pandemic that laid the groundwork for the messenger RNA vaccines and for the adenovirus vectored vaccines. So these vaccines didn't just come out of the blue. There was a lot of scientific work before the pandemic. So the scientific community was really well positioned to get these vaccines developed and then very carefully and rigorously evaluated. I know a lot of people are concerned that these vaccines were rushed, but they were very carefully evaluated, and there was a lot of scientific research behind them.
I agree. It is marvelous if you think about the work that's gone into this. So, when you think about this very short timeline, I guess people focus on 2 concerns, one of which is how effective are they, and second is how safe they are. So let's separate them. So my understanding is the initial trials on almost all the vaccines, give or take, showed about 95% efficacy. Could you describe what that means, the 95%, and in real life, after the initial trials, how good are the vaccines?
Yes, these are really important questions, and it's important for people to understand this. So we use the word efficacy to describe how protective a vaccine is in a very controlled setting, in a clinical trial. And these efficacy estimates come out of the large phase 3 trials that enrolled tens of thousands of people. And the way these trials work is that some people are randomly selected by chance to receive the vaccine, and others are randomly selected to receive either a placebo or sometimes it's a comparison vaccine. And then those individuals are followed over time, and we measure how frequently they get COVID-19. So when we speak about vaccine efficacy in the clinical trials, we're referring to symptomatic disease. That's what that was the main outcome of these clinical trials. And so basically what a 95% efficacy means, and that's what we saw for the Pfizer and Moderna vaccines in the phase 3 trials, is that those who received the vaccine were 95% less likely to develop symptomatic COVID-19 disease, than those who received either the placebo vaccine or the comparison vaccine. That's really remarkable. I don't think there were any experts who expected that we would see that high degree of efficacy. That led to the emergency use authorization by the Food and Drug Administration. And now we've vaccinated hundreds of millions of individuals worldwide against COVID-19. More than 140 million in the United States have received at least one dose. And so in that situation, then we evaluate what we call effectiveness. How does the vaccine work in the real world when it's not in a controlled clinical trial? And we're still seeing very high protective effectiveness of these vaccines in the real world. So this is really encouraging news.
That's great. No, it's amazing. I mean, I agree. It's been great. So let's take the other concern people have is safety. So tell me, and that's what we're hearing, and we'll get to vaccine hesitancy in a minute. But again, are these safe?
Yeah, this is a really important question. And, we hold vaccines to the highest safety standard that we can. And that's because these vaccines in general, and COVID-19 vaccines in particular, are given to millions and millions of healthy people. So vaccines are held to a much higher safety standard than, let's say, typical drugs or medicines are. Now, the vaccine safety is evaluated in each phase of the clinical trials. Small phase 1 trials are looking at safety. Somewhat larger phase 2 trials are looking at safety. Safety is a major outcome in the large phase 3 trials that also evaluate the efficacy. And then very importantly, we have a number of mechanisms for evaluating safety after a vaccine receives either authorization or approval and is rolled out among millions and millions of people in the real world. Now, what we learned from the phase 3 trials, particularly with the Pfizer and Moderna vaccines, but also with the Johnson and Johnson vaccine, is that people get what we call reactions, reactogenicity. And this is the inflammation. It can be local at the site of injection, soreness, tenderness at that site of injection. It can be some systemic symptoms, signs or symptoms, fever, muscle aches, fatigue. These are transient reactions. They last maybe from 12 to 36, 48 hours after vaccination. And that's what we really learned during the phase 3 trials. Now, there are some reactions or adverse events associated with vaccines, side effects, that we just don't detect in the phase 3 trials because they're rare. And that's why it's very important to have this kind of post-licensure, post-authorization safety surveillance. One of the things we learned is that some people develop a severe allergic reaction very shortly after receiving one of the mRNA vaccines. And that's why, as all of our listeners who've received a vaccine know, that's why you wait 15, 30 minutes after you get your vaccine to make sure you're not one of those rare individuals who develops an allergic reaction. Now, there's obviously, Dean Rothman, a lot in the news recently about these very rare but very severe blood clots that have developed, particularly with the adenovirus vectored vaccine. First noticed in Europe with the AstraZeneca vaccine, then with the Johnson and Johnson vaccine. And experts believe that these are probably related to receipt of the vaccine, but it's very important for both healthcare providers and vaccine recipients to be aware of these rare adverse events, particularly women younger than the age of 50 years. They seem to be at highest risk. Know how to recognize these and manage these early.
So, Bill, I have to ask, because people ask me all the time, you talked about people who have reactions after the first or second shot. Is there any evidence that if you have more reaction, if you feel sick after the second shot, it means that the vaccine's really worked on you better than someone else, or does it not correlate?
Yes, this is a commonly asked question, and for better or worse, it doesn't correlate. It does not correlate with protective immunity. It's a different aspect of our immune system that causes that early inflammation, 12 to 36 hours afterward. That's a different part of our immune system than the part of our immune system that develops protective immunity, the adaptive immune response, those protective antibodies and T cells. So although those kind of side effects are a sign that our immune system has seen the vaccine, they do not correlate with protection, and people can be fully protected even if they've been fortunate enough to have no side effects in that early period.
So, again, we're told to vaccinate everyone. Tell us a little bit about the people who are not presently vaccinating. And I'm thinking about two populations, one of which is children. And the other one is who we are vaccinating, but there's some question about it, which is pregnant women and also women of childbearing age. Could you talk about those two groups that I'm sure people are really interested in?
Yes, these are really important groups, and they were not those two groups, children younger than 16 or 18 years of age, and pregnant women, were deliberately excluded from the large phase 3 trials that led to the emergency use authorization by the Food and Drug Administration. For children, this is a very typical process. This is how the process works. We start in our evaluation of any new vaccine in adults, and then what we call age de-escalation, study the vaccines in younger and younger children. And when we get to the younger children, the youngest children, I'll say, we need to look at the dosing again, because the vaccine dose that we use in adults or even older children may not be ideal for the youngest children. So the way this process is working, and great progress has been made with the Pfizer, Moderna, and Johnson & Johnson vaccines in advancing this, is that the next group of children in whom we expect to see results are those children 12 to 16 years of age for the Pfizer vaccine, 12 to 18 years of age for the Moderna vaccine. And I expect that we're going to see an emergency use authorization probably in the coming months. I certainly before the end of the summer and before the next academic year. Pfizer has already released some of their preliminary data in a press report. Then what's happened now is that the clinical trials in younger children, 6 years to 11 years of age, 2 years to 6 years of age. Those studies are ongoing now, but I don't anticipate that we're going to get emergency use authorizations probably until early next year, early 2022, for those younger age groups. Now, with regard to pregnant women, this is a very important a special population for vaccinations. We know, and there's increasing evidence, that COVID-19 is a severe disease in pregnant women. They have 3 times the risk of developing severe disease, maybe 5 times the risk of ending up in an intensive care unit. We see this with other infectious diseases, the increased severity among pregnant women. So this is a very important population to protect. Now, again, pregnant women were not deliberately enrolled in the phase 3 trials, but over time, we've accumulated a lot of experience in COVID-19 vaccination of pregnant women. More than 35,000 pregnant women have been reported through the Vaccine Adverse Event Reporting System to the CDC. Looks like they may have some more soreness at the site of injection, but maybe even decreased systemic signs and symptoms. Very importantly, there's another mechanism that the Centers for Disease Control and Prevention has established for monitoring vaccine outcomes among pregnant women and their offspring. The CDC recently presented preliminary data on this About 4,000 pregnant women were included in this evaluation. And very importantly, it does not appear that there are any serious adverse events occurring among pregnant women who've received the vaccines.
Great. That's really great to know. So, Bill, here we are. It's 140 million vaccines have been given here. Tell us, to protect the population, how many people will we have to vaccinate? This comes to this question of herd immunity, which we've heard a lot about. Tell us about herd immunity, and tell us how many people you think we'll have to vaccinate here in the U.S., and will we get to that magic number, given the restrictions on children and all the things you've talked about?
Right. So, I feel that our most important metrics for evaluating how well we're doing with COVID-19 vaccination are looking at hospitalizations and deaths. We talked about vaccine efficacy, vaccine effectiveness, overall for symptomatic COVID-19. These vaccines, all three vaccines, are highly protective against severe disease and reduce hospitalizations and deaths. So I think our first goal is to monitor reductions in hospitalizations and deaths as a sign of the success of our COVID-19 vaccination program. And I think, Dean Rothman, we're already seeing evidence of that. If we look at hospitalization rates for adults over than 65, that's decreasing. We're seeing, unfortunately, increasing hospitalizations, and Michigan was a great example of this, in younger populations, 30, 40, 50 years of age. So I think our first goal is to reduce severe disease, reduce hospitalizations and death with COVID-19. Now, there's been a lot of discussion about herd immunity. It's a commonly used concept and metric in infectious disease epidemiology, but it's also a nuanced one, and I sometimes fear that we oversimplify it. But basically, what herd immunity means is that when you achieve a certain level of population immunity, it just becomes very unlikely that an infectious individual with SARS coronavirus 2 is going to come into contact with a susceptible individual. So people are this concept of herd immunity goes back to the early 20th century, and actually was described with cattle. That's why we use the term herd immunity. But it basically means that those susceptible individuals are kind of surrounded by protected individuals. So it just reduces the probability that susceptible individual is going to come into contact with an infectious individual. That's kind of the core of the concept of herd immunity. And there is a very simple analytic formula for calculating what that is. It's a kind of a back of the envelope calculation. And when you do that simple calculation, you end up with a kind of a level of population immunity, I'd say around 70, 75%. Now, that's not the vaccine coverage estimate, because the vaccine's not 100% effective. So the vaccine coverage estimate is slightly higher than that. So maybe we're talking 80, 85%. But again, it's a crude estimation, and it's going to vary basically by how frequently people come into contact. So that herd immunity threshold is higher in an urban setting than, say, in rural America. So there's not a one value really for the United States. And I sometimes fear that people think that, we reach this magical threshold and all of a sudden the virus is going to go away. That's not how herd immunity works. It just reduces the probability of transmission. Now, coming back to your question, can we reach, let's just say, take that for face value, 80, 85%. We know in the US population, 25% of our population is children. And so we're not going to achieve that until we start vaccinating children. And we have this problem or challenge, I'll say, of many people not wanting to be vaccinated. That's a complex issue. We kind of lump it under this term vaccine hesitancy, but there are many reasons why people are reluctant to get vaccines. Some are adamant, and no matter what we do, no matter what kind of communication strategy we have, we may not change their mind. There are other people who are on the fence, and who I think we can provide information. We need to listen to what their concerns are, what their questions are, and address those concerns.
So that's obviously something that's on everyone's mind because we like to get to this quote-unquote herd immunity. And I know, Bill, your center's thought a lot about that. Give us one or two things that you're thinking about getting those people who have some reluctance to take the vaccine. But what are the ways you approach them that you think are effective?
Yes. So first of all, I'll say that this isn't kind of a monolithic group of people. It's a very diverse group of people in terms of their age, gender, political affiliation. There's not a one size fits all here. And so the first message is that we need to listen to individuals' concerns. We need to listen to community concerns. We need to understand what the basis is for their reluctance. And we need to target our communication strategies directly to those. It's not a one size kind of top down approach. So the first thing is understanding what the causes of concerns are, and those are varied. Many of them are, as we were talking about earlier, related to this fact that people think these vaccines were rushed. They're unsure whether these vaccines are safe. They're unsure what the long-term potential adverse events may be with these vaccines, although we really haven't seen any of those. So those kinds of questions and concerns need to be addressed. But others have different concerns. And there is a lot of misinformation and disinformation out there that also needs to be countered in various ways. At the International Vaccine Access Center, we've been really focused in the Baltimore community about understanding what the concerns are, but really about engaging with the community influencers. Who are the people in different communities who are trusted sources of information? These can be the healthcare providers. Oftentimes, people's physicians are a trusted voice, but they can also be other types of community leaders, religious leaders, church leaders, who can speak to these communities and help correct some of the misinformation and help to provide that confidence in vaccines that builds the trust and helps encourage people to be vaccinated.
So, Bill, I'm going to do something very unfair, which is ask you to predict the future. So I'll put that. So, when we're hearing from modelers, people are thinking this summer, as we saw last summer, because more people are outside, we're going to see some decrease, as we do in most respiratory viruses during the summer months. So I'm going to start thinking about the fall. And the questions I'm going to ask you is, do you see a resurgence in the fall? Tell me the role of variants in that resurgence as you think about it. And then come down to this idea of if we'll need a booster vaccine, either because of the variants or because the immunity from the initial shot may not be sufficient. So give me a little bit about what you're looking over the next 6 to 12 months will happen.
Yeah. So, I don't think that we're going to reach some magical point where all of a sudden we're going to go back to our pre-pandemic lives. This is going to be a process, a phased process in which we slowly return to, more normal lives as more and more people get vaccinated, and hopefully in the United States as community transmission goes down. If we can get particularly the vulnerable, but really as much of our population vaccinated as possible, and we start seeing community transmission go down, we're going to be able to slowly return to normal, and we're going to see reductions in the restrictions, first for outdoor gatherings and then slowly for indoor gatherings. I think contact tracing, quarantine and isolation are going to be kind of our end game strategy. As you know, we're still going to see kind of pockets of transmission, and we're going to need to shut those down. Now, the issue of booster doses and variants is a very important one. Fortunately, thus far, the evidence suggests that our current vaccines are protective, particularly against severe disease, against the variants that we've seen now. The variant that was first identified in the United Kingdom, the variant that was first identified in South Africa. Our vaccines seem to be protective against those. Maybe some loss of efficacy or lower neutralizing antibody titers as measured in a laboratory, but still they seem to be protective against severe disease. But this is of concern. And what we need to do very rigorously is monitor hospitalization, I think particularly hospitalizations and deaths. What proportion of people being hospitalized and dying have been fully vaccinated? Because for me, that's going to be the real red flag. If we start seeing hospitalizations and deaths in people who are fully vaccinated, then we need to be concerned. So as you said, Dean Rothman, there are really kind of two reasons for booster doses or additional doses. One is if we see our protective immunity waning over time. And this is, again, we would detect this by detecting cases in fully vaccinated individuals. And so that's a true booster dose. And that can be with the exact same vaccine that we're using now. You're just kind of boosting that immune response. Now, if we start seeing these breakthrough infections with variants, then we need to really think about altering our vaccine. That can be done with a completely new vaccine, or we can combine the current vaccine with a vaccine that's protective against one of these variants. One of the great things about the technologies that we're using for COVID-19 vaccines, both the mRNA vaccines and the adenovirus vectored vaccines, because they use the genetic recipe for the spike protein, it's relatively straightforward to alter that so that we're injecting into our body the genetic recipe for the spike protein for one of these variants. So that's a really important feature of the vaccine platforms that we're using. They can readily be modified to address some of these variants. I'm hopeful that we won't need booster doses in this coming fall. I'm hoping for the rest of this year we can at least focus on getting our children vaccinated, first that 12 to 18-year-old age group, and focus our efforts on those who are skeptical about vaccines. And then maybe in 2022, again, I'm kind of predicting the future here. Maybe a year, 2 years, 3 years. Maybe we'll need booster doses. That's in the absence of variants to increase our immunity. If we start seeing these breakthrough infections with variants, then the game changes, and we'll need to not only focus on children and those who mistrust vaccines, but getting third doses out to everyone. And that's not going to be a simple logistical operation.
Wow, Bill, that's really helpful. So they're talking about variants starts to think about vaccines around the world because, as you know, one of the concerns people have is as this virus continues to replicate in populations around the world, new variants will come up that may be troublesome, as you described. Talk a little bit about vaccine shortage. So the U.S. seems to, most people predicting everyone who wants a vaccine will get it almost, pretty soon. And the question is, you start to look around the world, tell me what you think about vaccine shortages around the world, the concerns you have about that, and ways that we and others might help address it.
the United States, and I think justifiably, has focused on its own population. Up till now, we had a terrible outbreak pandemic in the United States. Really have led the world in cases and deaths. I think it's justifiable that we've focused on getting our own population vaccinated, and obviously the U.S. and government invested heavily in the research and development of these vaccines. But we're at a point where the United States really needs to play a bigger role in global vaccine inequities. And we're seeing, obviously, really tragic consequences of the pandemic in India right now. But India is not alone. There are other countries, Brazil, Turkey, that are seeing extremely high cases. And so now that we've kind of reached this point where more than half of adults in the United States are vaccinated, or at least have received this one dose, we need to turn our attention globally. There are gross inequities in COVID-19 vaccine access globally. Some recently reported numbers: 81% of available COVID-19 vaccines have gone to high-income countries, and less than 0.3% to low-income countries. And this needs to change. The big mechanism for doing this, for getting vaccines, particularly to the low and middle-income countries, is something called COVAX. This is a coalition led by the World Health Organization, Gavi, the Vaccine Alliance, and CEPI, the Coalition for Epidemic Preparedness Innovations. And they're really trying to lead this charge to procure vaccines, leverage the buying power of this coalition, and get vaccines to the low and middle income countries of the world. But it's been a slow rollout. There are a number of countries still that haven't even vaccinated a single individual. The goal is to provide sufficient number of vaccine doses so that all countries can at least target 30% of their population. And the high priority groups, the healthcare workers, those who are most vulnerable from severe disease. But a lot more needs to be done. I think we've seen, the U.S. Under the Biden administration has re-engaged with the World Health Organization. They've committed $4 billion to COVAX to help procure vaccines for low-income countries. But that needs to be where our focus is, and not just out of humanitarian reasons, although I think that's sufficient, but for selfish reasons. That's how we're going to, protect the United States. Otherwise, we're going to continue to see imported viruses, and I hope not. But as long as there are, large transmission of viruses in other parts of the country, as you said, there's the potential for emergence of new variants. And I just hope we don't see variants that really can escape the immunity provided by our current vaccines.
Bill, I have one last question. Some people have talked, as you think about trying to get vaccines to around the world, that perhaps for J&J is a single dose, so that one's easy, but the Moderna and Pfizer and AstraZeneca are all two-dose vaccines. What do you think of this idea about only giving one dose of those vaccines to people? Is that a reasonable idea?
So there's been a really vigorous debate about the use of a single dose, the way I would frame it is delaying the second dose. And there was a rigorous debate here in the United States about this, with experts on both sides of that debate. So this is certainly a question where experts can disagree. On the one hand are, perhaps the purists who will say, and Dr. Anthony Fauci has been on this side, the trials were with two doses. That's what the science guides us on. And there's at least a theoretical concern that if people get a single dose, there may be some partial immunity that may allow escape mutants to evolve more readily. So there are very smart expert people on the side that we should follow what the phase 3 trials told us, and that's around 2 doses, and that we should not be delaying that second dose. Although I will say that the timing of those that second doses was really done for convenience. The 3 weeks for Pfizer, 4 weeks for Moderna. That was in part to get us through the phase 3 trials as quickly as possible, so that we, in the midst of a terrible pandemic. Now, there are many other experts on the other side who say that we would be much better off from a public health point of view getting a single dose into as many people as possible. We now have, increasing evidence that there is protection conferred by a single dose. We're still learning the duration of that protection, but we're still learning the duration of protection of 2 doses. So in this debate with experts on both sides, I actually favor delaying that second dose and getting more doses into individuals, seeing if we can reduce transmission, and again, particularly reducing hospitalizations and deaths.
Bill, I learned a ton today. I so appreciate you taking the time to talk with us and all the work you've done during this whole pandemic. Bill and I get to be on Zooms together, and Bill has been really helpful for a variety of folks to inform them and to provide your expertise to people both here and around the world. So Bill, on behalf of Hopkins, thank you for what you've been doing during the pandemic, and thank you so much for talking to us today.
Thank you very much, Dean Rothman. It was my great pleasure to speak with you.
Thank you all for watching, and be safe and stay healthy.